Good evening to one and all. Hi, this is Dr. Gayatri, Professor Department of ENT. Today in this video, I shall be discussing about the routes of spread of otitis media. Complications of acute and chronic otitis media is an important exam topic for under ENT for both undergraduates as well as postgraduate students. To understand the pathophysiology of complications of otitis media, one needs to be aware of the routes of spread of infection from the middle ear and mastoid to the other intratemporal, intracranial and extracranial structures. Let's first familiarize ourselves with the various complications of otitis media. Complications of otitis media are classified mainly into intratemporal and intracranial. The intratemporal ones include acute mastoiditis, subperiosteal abscess, labyrinthitis, facial palsy, petrositis and Grady-Negro syndrome. Whereas the intracranial complications include epidural abscess, subdural empyema or subdural abscess, meningitis, brain abscess, lateral sinus thrombophlebitis and otitic hydrocephalus. The first mechanism of spread of infection from middle ear and mastoid is direct bony erosion. Bony erosion in acute otitis media occurs through pressure erosion caused by pus under tension or by hyperemic decalcification. Whereas Batten cholesteatoma is due to its property of causing osteitis and bone resorption. To understand the direct spread of infection by bony erosion, one must understand the relations of the bony mastoid. In this particular picture, we can see the various relations of the mastoid. The mastoid is related or bounded superiorly by the dural plate or the tegmen anteri. If this tegmen anteri is breached, infection from the mastoid can reach the middle cranial fossa and lead to formation of extradural abscess first and then subsequently subdural abscess and meningitis. If the posterior boundary, that is the sinus plate, is eroded, then the infection can spread to the perisinus space, the extradural space around the sigmoid sinus, leading to formation of perisinus abscess and subsequently lateral sinus thrombophlebitis. If the infection is proceeding anterosuperiorly towards the root of zygoma, it can lead to formation of zygomatic abscess. Whereas if the infection is proceeding medially, then it can lead to involvement of the bony labyrinth and the membranous labyrinth, leading to formation of labyrinthine fistula, serous and suppurative labyrinthitis. The infection from the mastoid can extend to the vertical segment of the facial nerve, and the infection from the middle ear can spread to the tympanic segment of the facial nerve, leading to facial palsy by direct bony erosion. Similarly, when the infection causes erosion of the outer cortex of the mastoid, it leads to formation of subperiosteal abscess. This subperiosteal abscess can track in various different angles. If the subperiosteal abscess tracks inferiorly along the sternocleidomastoid, it leads to formation of Bezold's abscess and parapharyngeal abscess. If the abscess tracks posteriorly along the posterior belly of digastric muscle, then it can lead to formation of Sitalese abscess. If it tracks towards the external artery canal, then it leads to formation of what is called as Lux abscess. So, if on the other hand, if the subperiosteal abscess breaches even the periosteum, it can lead to collection in the subcutaneous plane and formation of mastoid fistula. So you can see how much the infection can spread directly in all the different directions. In fact, you'll be surprised to know that the infection from the mastoid can even reach the cerebellum directly. This is through the triangle called as Trotman's triangle, which is bounded anteriorly by the solid angle or the bone covering the labyrinth or the three semicircular canals, then superiorly by the superior petrosal sinus and posteriorly by the sigmoid sinus. This triangle has a very weak bone. Mastoiditis close to this Trotman's triangle can lead to erosion of the bone in the Trotman's triangle, leading to spread of the infection to the posterior cranial fossa and the cerebellum. After seeing the extent of spread that can happen through direct bony erosion, let's see next the second most important route of spread, that is through thrombophlebitic spread. There is an extensive venous network between the extracranial, the diploic, the meningeal and the intracranial veins. Infection from the mastoid can spread via the mastoid emissary vein into the sigmoid sinus, and from the sigmoid sinus the infection can spread to the various other dural venous sinuses. Some of the common complications that occur through thrombophlebitic route are meningitis, subdural abscess and brain abscess. In this particular slide, we can see the schematic diagram of the dural venous sinuses. I wanted to show this picture to know how a thrombus in the sigmoid sinus can propagate. A thrombus formed in sigmoid sinus secondary to lateral sinus thrombophlebitis can extend into the transverse sinus and then reach the confluence of sinuses, and from there proceed upwards to the superior sagittal sinus. And in the superior sagittal sinus, it can lead to blockade of the arachnoid villi, leading to raised CSF pressure or otitic hydrocephalus. The other route of spread of the thrombus would be through the superior petrosal sinus and the inferior petrosal sinus into the cavernous sinus, leading to cavernous sinus thrombosis. The thrombus, on the other hand, can also spread downwards into the IJV and the right atrium. Lysis of the thrombus at any point of time can lead to massive septicemia and death. After looking on into direct bony erosion related complications and thrombophlebitic spread related complications, let us see the third route of spread, namely the preformed pathways. In this diagram, we can see that infection from the middle ear can reach the inner ear through the oval window and the round window. The infection in the middle ear, you can see in the CT image, can spread into the dehiscent facial nerve, leading to facial palsy in a patient with otitis media. A patient who has undergone stepidotomy is a potential candidate for spread of infection from middle ear to inner ear due to the minimal gap between the piston and the stepidotomy site. The same is the case with patients who have undergone Lempert's fenestration operation or stapedectomy. Through persistent incompletely fused suture lines or through fracture lines in patients with fractured temporal bone, infection from the middle ear can spread into the inner ear and intracranial structures. Infection from inner ear can spread to the meninges and brain and vice versa. How is this possible? This is possible through the three communications between the inner ear and the brain or the meninges. The connection is through One important connection is through the internal auditory canal, through which the 7th and 8th nerve enter into the posterior cranial fossa. Here, the infection from the meninges can spread through the nerve sheaths and enter into the labyrinth. On the other hand, infection from the labyrinth can also spread through the nerves into the nerves or around the nerves into the cranial cavity. Through the vestibular aqueduct and the cochlear aqueduct as well, infection from the inner ear can spread to intracranial structures. This is a picture showing the arachnoid villi projecting into the superior sagittal sinus, which get dysfunctional in a patient with superior sagittal sinus thrombosis, leading to otitic hydrocephalus. The last important route of spread is through the periarteriolar spaces of Virchow Robin. Here, the infection from the subarachnoid space can directly spread into the white matter without involving the gray matter of the brain. This is because there are these spaces around the arterioles of the cortex. So, the infection from the subarachnoid space spreads around these periarteriolar spaces of Virchow Robin, skipping the gray matter and directly entering the white matter, leading to formation of brain abscess within the white matter of brain. Finally, I would like to conclude stating the key points on the salient route of spread of otitis media. They are direct bone erosion, thrombophlebitic spread, through preformed pathways, through periarteriolar spaces of Virchow Robin. Thank you.